Stunning. All right, so welcome everyone who's on with us live and then also watching this recorded. This is our June ACOEP RSO Mentorship virtual series, and we have a couple really cool panelists that are on today to join us to talk about a topic that I know is in the back of my brain and the back of a lot of you guys' brains, and that is the start of intern year. My name's Sarah Turley. I'm the Director of Student Affairs for the ACOEP RSO, and I run these mentorship series along with a lot of the cool doctors that you're going to meet today. But I'm about to start my intern year, so I'm going to stop talking and let them share their wisdom because I know I'm really excited to hear it. But if you guys want to go ahead and introduce yourselves, we have some questions that are already prompted. If anybody has questions for these panelists at any time, please throw them in the chat. I'll help keep an eye on it and throw them questions as we go through. But I will throw it over to Alex to start off with introducing our wonderful panelists.
Hey, I am Alex. I am finishing up my intern year at LSU New Orleans. I went to med school at the Alabama College of Osteopathic Medicine in Dothan, did my clinicals in Mobile. So I just keep moving a little bit further west down I-10 to end up in New Orleans now. Uh, I guess a little bit about what our program looks like. That way you can get a vibe and a feel for how we run things is we have several pods at my program. So we have our acute resuscitation pod, which is where all of our traumas go and our very, very sick medical patients. And then we have pod one and pod two, which are both basically equal acuity. And then we've got pod three, which is kind of like a fast track area. And the way our program runs things is that in the AR, it's always a attending, an upper level, and an intern. So we spend a lot of our time in the AR pod as interns. Like that is where we almost primarily work. It's more of like I think I had 9 shifts in the last 2 weeks, and 7 of them were in the AR. So we are seeing like the sickest of the sick, all the trauma and stuff there. And the way we run things is that our upper level does head of the bed. And then we are in charge of all procedures. So we stand at the right side of the patient, and literally any procedure is ours. So I am basically done with my procedure numbers for this year to be able to graduate. So we are very, very busy. Each program has its different roles, and that's kind of why we wanted to introduce what our program looks like to give you the foundation of how and what we are talking about of how our intern year went. So I will popcorn it off over to Savannah.
Hey guys, I am Savannah. I am originally from Minnesota. I did my medical school at the University of New England up in Maine, and then my third and fourth year site was at Kent Hospital in Warwick, Rhode Island. And then I matched in Phoenix, Arizona at the old Maricopa County program, which is now Creighton of Phoenix, Arizona. We're a historically like county hospital. Our hospital system or our emergency department is switching to a pod system. We currently have a doc box system, but we moved into a new hospital in June. But essentially, our intern year looks similar to Alex in the sense that like our seniors take airway on all of our traumas and medical resuscitations, and then interns get to help with procedures or trauma surveys in that space. And then I think the thing that I like most about my program is that we have a really like broad variety of hospitals that we work at. So we go to Mayo and see the weird like neutropenic fevers. We work at our primarily county hospital. We also work at Banner University, which is the University of Arizona hospital, to get kind of that university piece. We work at Phoenix Children's, and then we also work at White River Indian Reservation. So we kind of have like a broad variety of experiences, but that's kind of my background and where I'm coming from. So Alex's program is a little bit more academic, and my program is a little bit more county, I would say.
Dina, you want to go ahead?
Yes, sorry. I was wondering if anyone else was going to introduce themselves. So I'm Dina. I'm originally from Central New York. I went to medical school at LMU Decom down in Knoxville, Tennessee. And I came back home and matched at Buffalo, which is mostly an academic institution. And we have like a pod-like system there as well. But we also rotate through a community and children's hospital in Buffalo as well. Um, I guess in the ED, it's kind of for traumas, it's mostly our third years that do the airway, but the interns kind of do the procedures and help with everything else that needs to be done. Um, but they allow us to do a lot as well, but it's more academic. I'm so awkward. I'm not used to doing like panels and stuff, so bear with me.
No, it's perfect. I think it's cool, and I think that this group of three panelists gives us a really cool wide variety. I met some of these people through ACOEP. I met Dina through med school, and I think them all being at very different programs, doing very different things, but all going through intern year together. I think these three ladies will give us a really good kind of showcase about the different things and their advice and what they did. So. I appreciate the three of you guys being on here tonight. Please feel free. This is a very relaxed environment. We want you to be as real as us as you can. So feel free, share whatever you want, answer whatever questions you want. But I know a lot of us on here would really benefit from any advice you have to give. So without further ado, I'll kind of start off with one of our first questions, which is I think your biggest challenge that you think looking at your intern year, so you're starting off, looking back on your whole year as and when, I think we're all kind of looking forward, like what is the scary thing that's looming? Is it the time commitment? Is it the knowledge? Is it feeling overwhelmed? What is it that was really the struggle and what are we looking to get ourselves into pretty much? But if anyone wants to start, feel free.
I guess I can start. There's a lot of like different aspects to intern year that I think are difficult. I think a lot of EM residents will echo off service time is hard because I think a lot of programs have a lot of off service months and you're just in maybe another hospital or on another service where you don't feel totally comfortable and you're just kind of by yourself on an island and it doesn't feel like you always have people to reach out to. For me, that's probably like our OBGYN rotation because it was at another hospital. I did it by myself. And you were on night, so just delivering babies in the middle of the night, like kind of on an island, was tough, like emotionally, and also attendings are asking you to present NSTs and things that you like haven't thought about in over a year. So that's difficult. I think also being a like stepping up to being a resident is hard right away, like fully owning your patients, and recognizing your knowledge gaps. Like when people aren't feeding you information or like helping you with your presentations, you're like, oh, it's all on me. And I need to kind of take ownership of my patients. And when I don't know things, I need to look them up or like find ways to like learn after shift. So I think for me, those are probably the most difficult parts.
Yeah, I totally agree. I had a weird schedule where I started in the MICU, which was tough. That was my very first rotation of intern year. So I was off and alone and by myself, which we have upper levels. So it's always an intern and a third year for us on the MICU, because I'm in a 4-year program. And it was tough being away while everyone was getting oriented to the ED. And then I rolled down into the ED after being off. And then the little things that my co-interns, because I think I was the only person off service. So a lot of stuff that like my co-interns had learned, I didn't know yet. So I roll in and I'm like, hi, this is my first shift. This is my first shift in here. I don't know how to do any of these things that you're asking me to do yet. And I got to get familiar with the system. But like people understand, like that is the learning curve of intern year. So like don't let that be the scary part. It feels a little bit intimidating and daunting to like not know how to put the trauma in Everbridge, like the little things that we have to do at my program. But we recognize that. I say we as we are becoming second years. Like we recognize that. We just went through that, right? So that wasn't the worst part. For me, with the way my schedule was front loaded. I had MICU first, but then I was in the ED for almost my entire fall. And then I was off service from January to May. So to me, the scary part was like kind of coming back after being off service for so long and then being expected to start doing upper level duties because they kind of escalate us as we finish out intern year. That way we are ready to be the upper level for our interns. So coming back and being like, I don't remember what a trauma is. I haven't seen one in 5 months. That was a little bit daunting. And I think to me, the biggest challenge now in reflection of intern year was something about I actually tweeted about it recently, and people replied and told me it's called the what is it, Dunning-Kruger effect, where you come in and you feel intimidated and it's daunting to be an intern, but you don't realize how much you don't know yet. And then as you go through intern year, like you finally start to get a hold on things, you're getting comfortable and confident. And then as you continue to go on, you realize how much you don't know. And to me, I had tweeted out like, is it normal to feel like you got worse this year? Because now I know how much I don't know, and that's even more intimidating going into second year. So it's this weird bell-shaped curve of like, you kind of get comfortable and then you kind of peak back down. And that was the, I don't know, I think biggest challenge that I'm facing currently.
I think for me, I agree with everything that you guys said. I can relate so hard. But I feel like the biggest challenge for me was being the actual doctor. I feel like you go throughout medical school and no one really anticipates anything from you. And then yesterday you're a medical student and today you're a doctor and nurses are asking you questions about things that you've never even like heard of. I mean, this is gonna sound so dumb, but like this one nurse was talking about doing something with a Dobhoff, and I'm like, what is a Dobhoff? And I remember like looking it up, and I was like, am I a moron? Like, how do I know what a Dobhoff is? I was like, how is that different from like an NG tube? Um, so I think just learning all the nuances of medicine that no one really taught you in medical school was super challenging. And like the equipment that you don't really have exposure to, and then someone's like, how do you do this? And I'm like, I don't know. Um, so that was challenging. And then also the fact that no one really holds your hand in residency. It's all um, it's like all self-driven. Like you have to put yourself down and study. You don't have monthly exams or weekly exams. It's like your ITE at the end of the year kind of directs you to like where you are. But no one is holding your hand and being like, hey, Dina, like you have to review these videos, you have to do these questions. So that was a little bit challenging as well.
Now,
Yeah, I definitely relate to all of those sentiments from these
Yeah.
guys.
I'll double down on that too. For anyone who's not a fourth year here, one thing I tell our sub-Is currently, or I guess anyone not a fourth year, that sounds so weird. You guys are all basically interns now if you're on here. But if you are not a soon-to-be intern or have started orientation, the thing that I tell sub-Is is when you tell me what your plan is, I really want you to think about the repercussions of what you're saying. Don't just say I want to give them pain medicine, but like what pain medicine, what dose, and why. And that way, like I feel like I did that as a sub. I was like, oh yeah, I'll just give them some pain medicine, help their pain. Sounds great. But then when you're the one putting in the order for the Dilaudid or for the morphine, you have to know the repercussions of your actions and like why you're choosing that stuff. So really like feeling the pressure of taking accountability and being scared that you're going to do something wrong was a steep learning curve for intern year. So I think challenging yourself if you're not about to be an intern and you have time to practice this, take the time to really think about everything you're ordering and your who, what, when, where, and why. And then also that being said, become best friends with your ED pharmacist if you have one, because they saved my life.
I was going to say that. I was like, this one patient, she wanted eye drops that didn't have like preservatives in it. And I'm like, how am I supposed to find this information out? Call the pharmacist. Like literally they knew it in like 2 seconds. It saved me so much time. Like have them on speed dial.
I did see a question in the chat, and this is definitely one of the questions that was on our list to talk about tonight. So, going into kind of you're doing your schedule through intern year, but with ITEs and board exams, some of our programs have already kind of started communicating to us that we should be planning to take these during this, that, and the other. But can you guys kind of share like your timing, when you decided, were you working, what resources for those big exams as we're taking on this already kind of big year?
Everyone takes the ITE at the same time in February. Like that's an all EM program thing. The advice that I was given from my mentors was to take step three around the time of the ITE because EM, the beauty of our specialty is we are so broad that it does kind of prepare you for COMLEX or STEP if you're a MD joining us. I took it a little bit later than I wanted to. I think I took it at the beginning of April, but that's just with my scheduling and the availability of the exams. That was the best time that I could get, but it's definitely worth it to schedule early because there are not a lot of exam dates for this exam, and they do sell out. So most of my cohort in my class has actually not even taken it yet. They're kind of waiting until second year, which is interesting, but that was their choice. They wanted to survive intern year, which is, totally understandable. I just went ahead and got it out of the way, and I am very glad that I did.
Yeah, I'm one of those that hasn't taken it yet, and I'm saving it for second year. I feel like the consensus usually is to take it sort of at the beginning of your second year, or like to have it done by the beginning of second year, which is what I'm doing and plan to do. But any time that feels right for you is like the time that you should take it. I mean, if you're like a fish out of water, like who wants to sit down for that exam? I think getting like on your feet and feeling a little bit comfortable should be a priority, and then take it when you feel comfortable.
Yeah, I took it the month after ITE, so I basically just studied for ITE using like the Roche question bank, which I think is what most people do. My program also pays for and mandates peer questions, which are through ACEP or like EMRA's website. So I did a handful of peer questions in Roche, and then I signed up for level three, which is a 2-day exam. When I was signing up, it was only available for me to take like one day, one week, and then the second day the following week. And you have to take the 2 days within like a couple weeks of each other or something. There is like a time limit. It won't let you like sign up for the second day past a certain date. So you have to like do it all together. And then yeah, after ITE, I just paid for like 1 month of a question bank and like did questions like most nights, did a couple of like the practice cases, and then just took level three. But like you really don't need to study for it that much as an EM resident. Like some people didn't study at all because all interns across the country have to take this exam or like either level three or step three. And there's definitely like other specialties that are far less prepared because it's asking you questions about peds and OB and also old people and men and women. And there's a lot of specialties that only see like subsets of the population. So I think they were set up pretty well. So I wouldn't sweat step three. If your program allows you to moonlight in second year, or in third year, you have to have passed step or level three before you can be like an independently licensed physician that is moonlighting. So everyone in my program pretty much takes it first year. We're a 3-year program, so I don't know. I think it's just differences and it really doesn't matter that much.
On the topic of you guys are talking about Rosh and some other things, what are your go-to resources that you have used throughout your intern year, whether it be on shift, whether it be when you're coming home, whether it be for didactics, anything like that? You can talk about test prep as well, but really the big things that you thought brought some clinical help to your intern year, especially, I think, because we're all kind of afraid of that gap.
I use Wikiem a lot on shift. I don't use my phone a ton. I'll use it for like MD Calc. Like I'll go in if I'm doing a CWA, like I'll whip out MD Calc on my phone so I can like look at the CWA score and all that kind of stuff. But I don't use my phone a ton on shift. But what I do is I'll pull up Wikiem, and Savannah just put a bunch of really great ones in the chat too. Like I'll pull them up on shift on my on the desktop, and that's where I'll reference stuff if I need it. I have continued to listen to EM Clerkship podcast, which I listened to all through med school and everything. I've continued to listen to that. I do use MRAP some, like if I, especially early in intern year when I just wanted like a procedure refresher or more if my upper level and attending wanted us to watch it before we go do it is like the new intern who's going to do a central line. Even though I did a bunch as a med student, they would pull up MRAP videos and have us watch them before we rolled in. MRAP's really great. People love listening to their podcasts and everything, but I don't find personally, I don't find their app that user friendly. Either that or I'm technologically like not savvy at all, and I cannot figure out how to like watch all their podcasts easily. So I just don't. But I definitely used Rush a lot. Like I said, I use TrueLearn for some board prep, but otherwise it's pretty much vibes and like case reading after shift. Like that's the biggest thing is like pick a case, interesting case that you had on shift, go home and read about it that night. And that's the way it sticks with you a little bit more.
There's a bunch of really good resources in the chat, so I'll make sure that we post those in the notes of our recording as well.
Yeah, I put my list in there for apps on Shift. I use the Super app, the Suture app. There's also a Nerve Block app. I will just show you what it looks like. I use it because it tells you like how long the sutures need to stay in and what you should be using. Um, this is like what the Suture app like logo looks like, and the Nerve Block one is the same. I'll look those up sometimes just because sometimes you don't know what you don't know, the Dunning-Kruger effect. Like look things up. You think you know stuff, but you don't know things. Like check yourself, fact check yourself, keep learning. So I use Suture app, the Nerve Block app. I use Corpendium, MRAP, up to date. And then the WikiEM app got absorbed into this app called like EOLAS now. It won't let you use like download WikiEM, I don't think anymore, but it's a good resource for like up-to-date articles. Outside of Shift, I use Corpendium, MRAP, Up-to-Date, Internet Book of Critical Care, Evidence-Based Medicine, and Life in the Fast Lane. These are just like a variety of resources that you can find quick articles on stuff you don't know. Like you see an atrial fibrillation case and you're like, okay, I'm not sure quite how to approach that. And you look it up on one of these things after Shift. And then you need to get EKG weekly. Mama too is a king. He is super smart. EKGs are hard. It's just pattern recognition and seeing a lot of them. If you don't listen to EKG weekly, I promise you, you will kill someone. I think like he just has like great like tips and tricks and like hard EKGs to look out for and like pitfalls, and he shows you cases of other people who killed someone so that you can learn from them and you don't have to like learn the hard way. So those are my recommendations, but you got to keep studying. It sucks, but we knew that when we signed up for it.
I'm I basically use what you guys use that you mentioned, but I also like the Carol Rivers review book. It's like kind of like first aid, and it comes with flashcards as well that you can use. Just because I feel like I'm the type of person that needs like a physical copy of something. I can't just go off and do questions and just like memorize random facts. So if you're like that as well, Hippo ED is also a good resource. It's a little bit expensive, but if you have like money through like your program that funds it, they can pay for it. But basically, they do videos. So if you're like an Anki person, maybe you can make flashcards from the videos and study that way.
I love it. These are all super good resources, and we will make sure that we get these out to everyone. Looking outside of the ED, another question that came up, Savannah, I think you were talking about one of the tougher things is these off-service rotations. Any advice for specific off-service rotations, how you went about navigating through that, what we can gain from them? I mean, I know that at MICU, there's a couple ones that are notoriously kind of the ones that are scarier. How do we deal with it, especially if that's maybe a place we're starting off at intern year?
My advice, I guess, is make friends with the nurses. They'll guide you. Bring chocolate covered pretzels from Trader Joe's. They're like $2, and it's the easiest way to make friends on shift. But yeah, be humble and just be there to learn and be a team player, all the stuff that you've done before. And then reach out to your co-residents, because if you're feeling lonely and isolated, other people probably are too. So share your those inner feelings because you will be validated, I promise you. And your cousins are there to like build you up and everyone's going through it. So OB is the worst, I promise. Every EM resident will probably say that. It sucks. You just gotta do it.
I started in the MICU as well, as Alexandra, and I survived. I think that was the only rotation I really like full on cried after I like ended the shift. Like I couldn't wait to get into my car and just like sob. That was my first rotation, but it gets better because all of my other ICU rotations after that, like I did not cry like that at all. So it does get better. I think you just like learn how to adapt. Um, and like Savannah said, rely on your nurses, especially in the ICU. They're like super intelligent and they can like tell you um, things and like take what they say seriously. I feel like arrogance is like a silent killer. If you're arrogant about something or you think, oh, the nurse, like, I don't care what they're saying. Like, if they're telling you a patient doesn't look that well, go and check on them because they're very smart and they know what they're talking about. Um, and just know that if you're at least a little bit better than you were yesterday, that's a win. Just take all the wins that you can get. And you're not the first person in the MICU, and you're not going to be the last person going through it. It's tough. It's just I think someone made a TikTok video and they were like, you just have to gaslight yourself. Like it's just 12 hours and then you get to go home and relax a little bit and then you come back and you're like, it's just another 12-hour shift. Like you can do anything for 12 hours and then you just keep gaslighting yourself for 4 weeks or however long you have to be on that rotation for.
Yeah, especially if you're in the MICU early like we were, the nurses know it's July 1st, right? Like they know there's interns up there. They know people are intimidated and like they're there to support you. And hopefully you're not alone on your ICU rotations. Like I said, we were partnered with an upper level, at least at my program. So I had a good bit of support. And it was a lot of like, hi, my third year upper level, who this is your like umpteenth ICU rotation because we do a ton of ICUs at my program. Um, help. And like you have this support around you. The number one rule of residency is get on the nurse's good side. They will absolutely save you time and time again, especially intern year, but all the way through residency. If they have your back, you're in a good place. And then also that being said, kind of like Savannah alluded to before, everyone is going through it. And it's a really important statement in med school to stay in your lane. But I say that even more strongly now in residency because I definitely had imposter syndrome. I still have imposter syndrome, and unfortunately, it never goes away. Um, but trying to really remind myself, like, I don't care how the other people are doing on shift. Mentally, different story. Like we can have our kumbaya moments and come together and support each other. But like, it's not my job to compare myself to my co-residents or my upper levels. And it's just my job to be here and learn and try to become the best physician that I can. So really trying to focus on yourself and growing on yourself. And like Dina said, like getting a little bit better every single day, you're going to grow exponentially through residency. And you might not feel it as you're going through it when you're in the trenches, but when you get to the intern year and you can look back and be like, wow, I actually kind of did learn a lot, even though I now know how much I don't know. And that's even more scary. Like you will grow so much this year, but make sure you're staying in your own lane. Don't compare yourself to how other people are doing. Everyone's going to be strong at different things. Don't stress yourself out for reasons that you don't need to on top of already being stressed of being a resident.
And make your life easy on ICU rotations by rounding. Like during the daytime, it's a little bit of a different story, but at nighttime, if you go and round on your patients at the beginning, s- depends on like what institution you're at. Sometimes they'll have like a huge list and you can't possibly do that. But if you go to the nursing pods and just ask like, hey, like I'm the nighttime resident, what do you guys need for tonight? And they'll just like shoot out orders for you and you can sit there, just order everything that they need. And then usually if they have like a face to the pager, they're like less inclined to annoy you about like the miscellaneous things like melatonin, for example. So that's one of my biggest tips if you're doing nighttime ICU.
Yeah, I second that round if you're gonna go take a break or something or like lay down for half an hour, like go talk to every nurse or like each pod, whatever your system is, ask if there's anything that they need. That's super good advice. And then if your senior is going to go sleep for the night and leave you by yourself in the MICU and someone is sick or more critical, just kind of take a minute, run through possible situations. Like that's our job in emergency med, is to think about like what could kill this patient, what could go wrong, how could they decompensate. So just kind of run through that so that you know what to do or like what action items to take, especially if it's early on in your year. But yeah, and lean on the nurses.
And don't be scared to wake that senior up. Like that's their job. Like, hello, this patient is not doing too hot, and I'm just the intern. Um,
Girl.
and then I feel like as an intern, you have that excuse behind you. I'm like scared to start PGY2 because I can't use that anymore as a crutch. Like, ask all the dumb questions that you possibly can because as you go up in residency, it gets a little bit harder and harder to ask the dumb questions. But you're in residency for a reason. No one expects you to know everything, but as an intern, ask all the questions. Um, so yeah.
So we talked about working with our nursing staff. What about working with attendings with their different preferences? How do we go about kind of learning our own craft and learning the knowledge while also trying to learn what each attending prefers and the guidelines that they're following? What advice do you guys have kind of working in that hierarchy system as a resident?
That's definitely one of the tougher things of our specialty, right? Like emergency medicine specifically is an art and a craft, and there's a lot of things that can be done stylistically to each attending. So I think the biggest thing that I learned this year from asking my upper levels that exact question was be a sponge intern year. Intern year is kind of your time to learn everyone's practice and start to formulate what you think you want to do and how you want to be and how you want to, practice when you're an attending. But for now, your job is to be a sponge and learn as much as possible. And then as you progress through your years, I'm in a 4-year program, so like I have plenty of time to decide how I want to be. But be a sponge intern year, look at how everyone runs things, pick up on things you like, pick up on things you don't. And then as you progress through your years of training, that's when you get to adapt and mold to how you want to be. If you like, we definitely have some upper levels at my program who were like, you know, trying to be autonomous as fours, and at a lot of programs in the country they'd be attendings already, so they would like feel very strongly about how they'd want to do something, and an attending would be like, well, just put this in. So like make note of it, but know that might not be how you're going to practice in the future.
Yeah, I think everything Alexandra said is really good advice, especially being a sponge your first year. Um, don't argue with the attending. I think that is like the worst thing that you can possibly do. You're just going to get on their bad side. And then after all, you are practicing under them and you have to respect that. Like at the end of the day, that's their say. What they want to do goes. But I think you should always offer up your plan. Like suggest what you would do. And if they shoot it down, just be like, hey, in like the most respectful way possible, just be like, hey, why is this better than this? Or why do you think we should do this instead of this? Just so you can learn. That's like a really easy way to learn on shift, because then you can figure out like why they don't want to do that and like what the repercussions are of doing what you suggested. Um, and then I rotate through several different hospitals, so everyone has like a little bit of a different preference. And sometimes I forget. I think I want to start making like a little notes page. Um, if you work with like a particular attending all the time and they like things a certain way, I think you can like write it down in a little note page and just remind yourself when you come back to that hospital after like months of being away. I think that would like help a little bit, but I haven't done that myself. It's just something new that I might try out for PGY too.
Yeah. I think as far as like working with different attendings goes, right away with each attending, just give your formal presentations that they know that you know what you're doing, what you're talking about as things go on. If it becomes a little bit less formal, I think that that's sort of a natural process, but right away I'd give that formal presentation and then kind of oh shoot, I lost my train of thought. one thing I wanted to say is if you get feedback from an attending or criticism, know that I always tell myself that this is someone who cares about me and is trying to like better me as a doctor and as a physician. The path of least resistance and like the easy way is just not say anything, let you go about your way, like making the same mistakes. So if someone is reaching out to you and giving you feedback or telling you how you can improve in the future, that's someone that cares about you and your education and your progression and ultimately you becoming the best doctor that you can be. So I always try to keep like that growth mindset, which isn't easy to do, especially at the end of a long shift. But yeah, and just be teachable, don't argue.
Be a sponge, but be a tough sponge. We're going for like scrub daddy here. Let's
Yeah.
just say. I outside of the ER and everything that we have to do, we had a couple questions in the chat, and I know this is something that I definitely thought that these three people, yes, Scrub Mommy, would be great to talk about with, is that life balance and what life is going to look like for us outside of the ER, maintaining things that are important to us, scheduling things in advance. I saw a chat about schedule uncertainty and how to plan ahead for things. I know I have a wedding coming up and things happen, and can you guys talk about that change? How hard it was? Was it easy? Do you find that you have a balance? I know it's very personal to programs and scheduling, but kind of talk about what you've noticed and any advice you can give us.
My biggest tip is to do everything tired. Um, I mean, you're chronically going to be tired. Like in residency, I'm not kidding. Like I'm always exhausted. But if you constantly live in this state of, oh, I'm too tired to go out, I'm too tired to do this, you're just, your whole entire life is just going to be consumed by the hospital and coming home and sleeping, and that's it. So do everything tired. If you get out at 7 and your co-interns are like, hey, like let's get together at 7:30, it's not going to kill you to go out for like 30 minutes to an hour and grab a drink with them. I feel like once I realized that and started doing more of that throughout intern year, I feel like at the beginning I just came home, went to sleep, went to work, and that was my life. As soon as I started branching off and like attending like social hours and doing things that like make me happy, like workout classes and stuff like that, I noticed that I had a lot more energy, and it was like revitalizing in a way. I feel like it like kind of like how a vacation refreshes you. These little social hours like refreshed me for like the next day. So just do it tired.
Yeah, that's excellent advice. You're gonna be tired anyway. You might as well hang out with your friends and kind of fill up your cup in that way. And then as far as like having a partner in residency, I think my best advice is just communicate really well and like plan ahead. In terms of like I'm married, my husband and I'll like give him my schedule for the week or the month and kind of like set expectations at the beginning and be like, hey, next month it's gonna be a super busy month. I'm in the MICU, but like I have this weekend off or like this night off. So it'd be really great if we could do a date night or like if you could save that night for me. So that kind of communication and like setting expectations, I think, is really important. And then also, if you have things like weddings and stuff like that, be a team player, be that person that's gonna like switch a shift with someone, take one for the team. Like, okay, yeah, you're working Friday and Sunday. I can take your Saturday night and you'll get me back in the future. Like, those kind of things go a long way. And I think people are more willing to swap with you and help you out if you're going to be someone that's a team player that's going to get them back and make sure that they get that time in the future, sort of thing.
Yeah, my husband and I were doing distance for this year. He was a surgery resident up at Hopkins and moved here on Saturday, so we're back together. He is currently doing things all in the living room. I'm not used to hearing sounds while I'm on these Zoom calls, so it's kind of fun. But we would schedule like FaceTime date nights. Like we would watch full movies on FaceTime together and like plan that kind of stuff out. We didn't get to see as much of each other in as I had hoped, which was primarily because of his schedule. That is one of the beautiful things about emergency medicine is we do shift work, right? So like if you need the weekend off, hopefully your program will give you that weekend off. We at my program get 2 golden weekends a month. We technically do 2 week blocks, so you get a golden weekend per block, which is really, really nice. And like that a lot of time has been coupled with like I had to go to a wedding in Huntsville, Alabama, which was a like 7 hour drive. I got Friday through Monday off and I only requested Friday afternoon, Saturday, and Sunday. So like my program is super supportive of being able to go to things. I absolutely agree with doing things tired, but also like making sure you're protecting your peace. Like residency is exhausting, and if you overindulge, as you know, in whatever activities that it might be for you, you may be really tired and also not being the best resident you can be. I'm a big advocate going out. Like I've made friends with like our pharmacists and I have friends at other programs and we regularly get together. But then there's the occasional time where I'm just like, I'm exhausted. I haven't studied. I can feel my empathy levels dropping on shift. That's how I know when I'm hitting a burnout level is I am not empathetic towards the things that I would normally be. And I have to do that to like check in with myself of what do I need to do to recharge my battery so I can come in and be the best resident that I can possibly be. Because that is ultimately our, purpose of being in residency is to grow as a physician and be a very competent emergency medicine doctor. So finding the good balance of working out, going out, whatever it is that you enjoy doing, having date night. And if you are a homebody, that is also absolutely okay. But do whatever you have to do to protect your peace in residency because it is very, very important.
And also try different methods of kind of getting your work done. At the start of the year, I was taking my notes home with me and like doing them when I was watching TV or like hanging out with my husband at home. And recently I've just started like finishing my notes after shift. Um, and I find that I can get them done in like a third to a half of the time when I'm actually just focused. And then I get to like really enjoy my time at home and feel like I have a better like separation between work and my personal life. So try different methods, intern year, figure out what works for you, and try to make sure that your home time and your off time is really off.
Yeah, do not take your notes home with you. It's like a sticky trap to like fall into because then you can easily get really behind and then you're like, what the heck? So just do it after the shift, honestly, like your future self will thank you.
Everyone has a different strategy for how they manage notes and stuff. Like I personally, like I said in the chat, I refuse to take notes home. And I typically refuse to have notes after shift. Like that is my goal is if a patient is dispoed, my note is signed. And I am fortunate that I worked as a scribe for 2 years. So like I can whip out a note in no time. So to me, that's not something that slows me down. But if you haven't had a lot of experience writing notes, and especially when you're getting used to writing MDMs and stuff, it can be daunting. But like one of my upper levels on my shift yesterday was just like, Alex, oh man, what a shift. Like your notes are already signed and we're out of here. And she was like, I love working with you because I never have to stay to do notes. And that's just, I mean, granted, sometimes things get out of hand in our AR pod. Like I did not sit for the first 5 hours of my shift yesterday. So like I was behind on notes when I got to the computer, but I sat down, I looked at what orders need to be ordered, like I looked at the like results. You can put little notifications on if you use Epic as your EMR. You can put notifications for lab results because that's the biggest thing that I struggle with balancing early on is I would sit down, I would do orders and I'd want to do notes, but then things would be resulting and then my attending or upper level would be like, "Hey, did you know something's back on that patient?" And I was like, "No, because I'm getting my notes done. Like I'm not just sitting there hitting refresh on the results." But instead, if I know I'm waiting for something in particular, I set the little like alarm button on the result that I want, and it unfortunately goes to my Apple Watch first, which is kind of annoying, but I know that the result is back, and so I can stop writing the note for a second and then go take care of what I need to take care of and then go back to doing my notes. So I am very much an advocate of don't wait to do notes, but I have some of my co-interns who they didn't have a lot of experience with notes and they don't do any notes on shift. They are just focusing on surviving, getting through their shift, and they will go sit in the other pod and do all of their notes afterwards. So I personally don't love that technique, but you have to do what makes you the best physician on shift. And if that's how you're gonna, get through your first couple months, that's totally acceptable.
I think coming back after every patient and just doing the HPI and then at least the pertinent positives that you found like on your physical exam, just jotting that down and then you can fill in the rest after shift if it's like a crazy shift is a good idea as well. Because if you see so many patients, you're going to get confused. You're going to be like, was it this patient that had this? It's very easy to confuse patients when you're seeing so many. So just get that HPI in and then pertinent positives that you found.
To go back on that too, one great thing of to get in the habit of is running your list. Like you should be running your list, talking through everyone who's on the board regularly because that's how you know you're keeping up with stuff. So we call it like one of my upper levels, let's call it like RTL time. So she'd be like, it's RTL time. I'd be like, run the list, run the list. You just run through all the patients that you have and you go back to business. And then you're keeping up on top of everything. You're not losing anything, especially on hectic shifts. Like you want to make sure you know what's going on in your area.
Yeah, and there's different ways to do that too. Like I use sometimes like there's like a MD comments thing in the Epic track board. So I'll like put comments in and just kind of remind myself what we're waiting on so I don't have to like think about it again and again. Like, okay, I'm just pending the CT and then I'm in dispo, like I need labs and dispo. And that can help you to like be a little bit faster. Some people use like a paper pencil method and writing stuff down, but
And just remember, as an intern, your job is to learn, it's not to move the meat. That's why you have seniors. So don't like think you have to see every single patient that pops up on the board. Like that's not, um, it's not doing your learning justice. So just like take the time with your patients, especially at the beginning. And then towards the end of the year, you can like kind of work on seeing more patients if that's what you need to work on. But at the beginning, just focus on why you're doing what you're doing. Um,
yeah. That's really good advice. And you're here for 3 or 4 years to learn, and that is your role, and like your program owes you that and like should support you in that. So take your time, build your foundation, and then you'll just naturally become faster, I think.
And a lot of it is how your pod is set up. Like I know some programs do a free for all. Like if someone pops up on the track board, it's whoever can grab them is going to go see them. We get assigned rooms, so like we are split in the pods. So like I take evens for the day, and the my other resident takes odds or whatever it is. But we're always split unless you're being charged. We have it's kind of a complicated, nuancy thing that we do, but basically, as a intern or a second year, you're always seeing like 7 rooms. If you're in our pod system in the AR, it's a free for all because the sick people go there, and if they get stabilized, they will get moved to the pods if we're out of bed. So you can just be churning through people in there. So there's not really a set amount of people that you're seeing. But we, like I said, you carry 7. And for some people, intern year, like if you get a wide open board of 7 new patients, like that can be overwhelming. And it's okay to ask for help from your upper levels who are on shift. Like that is what they're there for. So you can run 7 rooms or you can run 4 and your upper level can do 10, like if they're capable. And then as we move up into our upper year, third and fourth year, we're running 14 rooms. We're overseeing the entire pod. So it's kind of like a, I don't know, graduated responsibility, if you will, but I don't like calling it that. I think it's just becoming more adequately prepared to be attendings.
And from like a numbers perspective, if you're seeing like 3 or 4 people or like one patient every 2 hours, your first like month of intern year, like that's fine. That's okay. Like you just build your foundation, get used to the system. Like there's a lot of like learning pieces, so don't sweat it. I think my first couple like internships, it's like, oh my gosh, I saw 5 people in 8 hours. Like that was a lot. And like you just kind of grow from there. So don't sweat it. Do a good job, own your patients. You're like putting in orders and like dosing meds for the first time, and it's a big learning curve. So take your time, and everyone understands that in terms of attendings and upper levels. So
When you guys, I think this is kind of going to be my last question before I open the floor for any other additional questions, but when you guys are on shift, I know you talked about running the list. Any other specific things that you feel like made your shifts during intern year in the ED go better, more efficiently, ways you found to keep yourself organized, pitfalls, anything we can do as we start these first couple shifts that might give us a little leg up or help us kind of set ourselves up for success in such a very new world that we're going to be in?
If you're consulting anyone, you have to have a question for them. You can't just be like, hey, this patient's here for abdominal pain while you're calling surgery. They're going to be like, okay, like, what do you want me to do? Is there something surgical that you're concerned about? Like, you have to be like, hey, I'm concerned for appendicitis. Um, Otherwise, they're just going to give you attitude. I feel like it took me a little bit to get that down because I used to call them and just spill like the entire story, and they're like, okay, but why are you calling me? Like, why can't you manage this? So very important to have a specific question for whoever you're consulting.
What helped me at the start of intern year was just like running my list. Like basically every time I get back to my computer, sit down. And then if you can discharge people, discharge them. Pend orders and like get things rolling on your patients. But as soon as things are back on your patients, try to disfill them and get them out of there. That will kind of free up your mental load, not to have someone else to think about, and also get them moving and like on with their day.
I think early on, going in and recognizing the sick and not sick. I know you hear that a lot as a sub-I, but sick and not sick. But then also, what is the next step with that? What is their dispo? Are they discharge or admit? Like starting to identify those early on, even if you're wrong, that's okay because things change in the shift, right? You can get a result, you're gonna be like, this is like not, I'm not worried about this chest pain, and they pop a high trope, and that might change how you manage everything, right? So like going ahead and mentally saying like, are they sick or not sick when I walk in the room, and am I admitting or discharging? The other thing I will say is get into a habit, whatever that is for you, on how you take sign out and how you take notes for your patients. And by that, I mean, I don't take notes in the room with my patients, but I have on shift a list where depending where I'm working in the AR, I don't write room numbers because their room numbers change so much. Like they might come into our main 4, 5 resuscitation rooms and they get moved into the other rooms in there, and then they might go to a pod. And then if someone's telling me like, oh, patient in 2643, I'm like, there's no one on the track board trying to just give me their name. So like in the AR, I write names down. That way I can see where they are in the rooms. But then in the pods, people aren't really bouncing around. So I will just write room numbers there. I will write their chief complaint. And then I do personally 2 check boxes and a circle. And so the first checkbox is that I did my note. The second checkbox is that I've updated the ED course with results. And when I say I did my note, like I will do my HPI, my ROS, my physical exam, and my MDM as soon as I sit down. And I will live in my ED course otherwise. If you don't know what ED course is, it's an epic thing where you don't actually have to go back in the note to update the note. It's amazing. And it saves me a lot of time from not having to re-click back into the note. So every single MDM, I know it's my note if I'm reading back on notes because I always say, please see the ED course for further commentary on the patient's ED evaluation. And then everything else is in my ED course. Every lab result, every imaging result, any consult, all that kind of stuff, it chills there. So my first check mark is that I did everything up to my MDM. My second check mark is that I actually updated the ED course with all of the results. And then my circle is where I put in my disposition. Like once I've discharged them or admitted them, I just put DC or AD in the little circle, and then I scratch through it once it's been signed. So like I just have that little system for me, and that way I always know where I am on my notes and on my threads and all that kind of stuff. Um, what else? I think that's kind of the big ones.
Yeah, I think Alex made a really, really good point there in terms of make like be decisive, and you can be wrong and that's okay. And like we all know that they've proven that doing questions and being wrong is a great way for us to learn. That's like why we all studied for boards that way, like doing a whole bunch of questions. Kind of the same idea on shift. Commit to your patient plan, the labs you're getting, the imaging. You can be wrong, but present that fully to your attending. And if they give you feedback, that's just like a good learning point. Or if you get a CT that's negative, it's just good feedback for yourself. Like, okay, maybe the next time I wouldn't get that. Or maybe you choose not to image someone and then they have crazy LFTs like showing an obstructive pathology, and you're like, okay, should have gotten imaging on this person, but all of those like micro commitments kind of help you to learn and shape your clinical practice.
Also, if you are at an academic program, it's very easy to just allow other services to do the job for you. And as an EM doctor, a lot of these things are within your scope, but sometimes you're just consulting ortho, for example, to do like a reduction, and they'll come down and do it. I feel like you should prioritize like being in the room at least. Some policies, like for example, at our county hospital, we have to consult ortho or trauma or whatever for anything, and they have to come down and do it. But I make the initiative to be in the room with them while they're doing whatever procedure that they have to do for the patient. So I'm also learning because if I'm at a community hospital and this comes in, like how like what am I supposed to do? You know, you have to know those things. It's not just about triaging, um, like knowing how to triage a patient.
And don't be afraid to be an advocate for yourself because we like to think that attendings from other specialties understand what emergency medicine is, but they don't. They're not emergency medicine doctors. So, like, I was at the VA and I had a paratonsillar abscess, and I was really pushing for me to get to do it with my attending, but they didn't really feel comfortable doing it because they didn't get to do it a lot in their training. So, they wanted me to call ENT, and then I told ENT straight up, like, I want to do this. And they were kind of like, I don't want to say blowing me off. Like they were very respectful, but I finally looked at them and I was like, this is in my scope of practice. If I am in a community, I am expected to do this by myself. And they were like, oh, really? And so they let me do it. And they also, because I had that conversation with them, opened up the opportunity for us to go to the OR with them to do like tonsillectomies so we can have a better understanding of anatomy. And so that's like a new elective that we can do now just because I opened up the conversation of wanting to get to do a paratonsillar abscess that they didn't realize was like in our scope of practice. So don't be afraid to advocate for yourself, especially if like ortho's coming down to do a reduction and it's the upper level. They've got their numbers in. Ask them if you can do it. Ask them if they could show you how to do it. Like give them a participatory role in that setting, and you will get a lot more fruitful of an experience in residency.
I carry a scalpel in my pocket to every trauma, and if they need a chest tube, I'm like, oh, weird, I have a scalpel and
Weird, I
a
have a
fork.
little bit.
I'm just ready to go. But this is bouncing off Dina's comment, but also like you're only going to be as good of a doctor. Like everything is about how much effort and time, like effort you put in. So read all of your CT scans, read all of your x-rays, interpret your labs, like make sure that you're fully like owning your patients and taking advantage of all of those experiences, because if you never open a CT scan for all of residency, you're never going to know.
And sometimes at the community hospital that like we rotate through, you are the radiologist at nighttime. Like they don't have anyone reading it. Like you're reading the chest x-ray. So you have to really know how to read your own images. Um, Very important.
And radiologists aren't perfect. They miss stuff. We've caught stuff that they didn't see. So it is really good. I'm guilty of it, like especially in our like AR pod because I have an upper level to rely on and my attending. Like it's easy to not want to open those images, but that's where you can go into just giving yourself a challenge every day. Like when you're an upper level, like you're kind of expected to look at those kinds of things at my program. Intern, you're not. So when I had my upper levels early on asking like, what do you want to work on today? I was like, I want to make sure I look at every single chest x-ray that is taken in this pod today. And they worked with me to do it, right? Like I could have easily blown it off, but I looked at every single chest x-ray that day. Or like, I want to look at every single EKG. When the EKG techs come over, let me look at it. And before you guys look at it. And so just giving yourself a little challenge every day is also really helpful early on to set mini goals.
I like that, Alexandra. I think that's really good, to go in every day and have a goal for yourself. And I think voicing that to the attendings is a good idea. I feel like I set goals for myself personally, but allowing like other people on your team to know your goals, they can help you achieve those things and kind of you have like an outside person pushing you because sometimes it's easy to get lazy and just be like, oh, I just won't look at that. It's fine. So if someone else knows that that's your goal, they'll be handing you the EKG or whatever it is. Um,
And it's a really great way to get feedback too, because we know people aren't always the greatest at giving feedback. And like I challenge my attendings all the time, like, give me not negative feedback, but constructive feedback. Don't just tell me I did so great today. Nothing to say, nothing to comment. I'm like, no, there was something this shift I could have done better. And by giving them a goal, they have something to evaluate you on because you have something that you're trying to work on during that shift. So it gives them a specific, frame of reference of, oh, she's trying to look at EKGs today. Like, how did she do on them? What advice could I give her to be better at them? So it also is a way to help you get better feedback on your shifts.
That was all absolutely insane, beautiful advice, and I will be rewatching this the minute before my first shift on Saturday. But we are getting close to 9 o'clock, so I just want to really quick, we'll stay on and answer some more questions, and I'll open the chat up for anyone who wants to stick around and talk. But thank you so, so much to these three wonderful women who have come and talked to us about their experiences. I mean, it's so cool, I think, too, as being kind of someone right behind, watching them go through now. They're about to be second year docs. I think you all should give yourselves the biggest pat on the back because you guys have been such a great resource for us and cannot wait to see the great things you do as PGY2s. And this was very helpful for me, I know, and a lot of the new interns sitting here. So thank you guys for your time, for your energy, for your great advice. And thank you everyone who's on here now and watching later. But I'll stop recording. Our ladies will stay on if they need to go. You guys can head out. But anyone who has any other questions, please stick around and feel free to ask, use their knowledge. We do have Scientific Assembly that is coming up in September. That is our conference. That is going to be RSO programming is the 22nd and 23rd. I believe it's Tuesday, Wednesday. It's right back to back with OMED. So if you're going to OMED, that's also an opportunity. But we also will have our lecture series next month, which will be going over audition rotation. So we will send that out. But I will stop recording. Thank you guys for watching, and we'll stick on for a little bit.